Good afternoon, everyone. You're so great to see you here. I know we have some of these people joining us on Zoom as well. Welcome, I'm Angela Hoffman, and I am the Physical Professor at Brown School. It's a pleasure to welcome you here to our series. This installment is our last one for the semester. We wanted to that's the last. And we had a pleasure of collaborating with the International Center for Child Health and Development here at the Brown School, the ICHAD faculty and staff who are also being continued today. Introduce our speaker, Dr. Proscovia today. Who is an assistant professor here at the Brown School. Global research focuses on HIV-stigma reduction, intervention, mental health, and support systems as protective factors for the development and well-being of children and families impacted by HIV. Expertise in poverty reduction strategies that utilize asset-based intervention and their impact on children and families, social, economic, and health well-being of HIV and Africa. She is principal investigator of two projects that are examining the longitudinal HIV treatment adherence, outcomes among youth living with HIV, transitioning into young adulthood, and also evaluating the long-term impact of an economic empowerment intervention on HIV risk, prevention, and care continuum across outcomes among orphan youth transitioning to young adulthood. So we are super excited to have her here and share her expertise and experiences with us. And without further ado, I'm going to pass the mic to Dr. Nabunya. Thank you.
Thank you. Thank you so much, Angela, for the introduction.
You gotta push the button.
So as they're handling that, I would like to appreciate the public health speaker series and our ICHAD speaker series for inviting me to present to you today. And thank you to all the students and the faculty who are in here today to listen and to some of the studies and the research that I'm doing. So today my talk is going to focus on HIV stigma reduction interventions, part of the work that I'm doing in Sub-Saharan Africa, specifically in Uganda. And it's going to be structured into three parts. So the first part is really going to talk about some of the work that is informing my interest in HIV stigma and mental health. And then I'll present a study and findings for a pilot study that I did addressing HIV-related stigma among young people and their families. And then the third part of that, I'll talk about my current work, my ongoing studies, and also some of the new studies that have recently been funded, and I'm excited about that work. And I also put this quote because I thought it aligns with what I'm doing today. So without addressing HIV-related stigma and discrimination, the world will not achieve the goal of ending AIDS as a public health threat. So in my the first part of my talk will also address how HIV and stigma and discrimination intersect with public health and why this is a public health challenge that needs to be addressed. And before I go any further, I would like to acknowledge the funding, the incredible team of people that we work with and who actually implement this research field. So we have a huge team of over 60 people in the field.
I can't hear her.
Here at the Brown School who are helping to implement these studies. Most of the funding is from the National Institute of Health and specifically National Institute of Mental Health. But also we have several collaborators both in country and also here at WashU and the Brown School who was there. Okay, so I'm going to start with the big picture of the global HIV pandemic. So we know as of 2021, about 38 million people are living with HIV. And if you look at the map, where the majority of the numbers coming from? Right.
sub-Saharan Africa. So the majority of people living with HIV are living in sub-Saharan Africa. So also, if we go down to look at just the children between 0 and the age of 18, we see that the area of Sub-Saharan Africa has more than 1 million of them. So 1.7 million are living with HIV globally, but over 1 million of those are living in Sub-Saharan Africa. So think about these children, they are growing up, they're born with a disease, right? But they are going to grow up with several challenges. They have to go through adolescence where they have to encounter the physical, the mental, the psychological changes that comes with just growing up. But on top of that, they have to manage HIV treatment and medication. This is complicated. We have to, depend on their caregivers. But also the third level of that, they have to live with this disease which is highly stigmatized, right? So those are 3 things that these kids have to grow up with. So the second factor, and which goes hand in hand with HIV, is the burden of global health. Okay. So mental health disorders account for 16% of all the global burden of disease among young people 2019 years. In Southern Africa, 1 in 7 adolescents have significant mental health challenges. And the problem with this is that we do not have the resources actually facilitate our education and diagnosis of mental health challenges. We don't have the trained care professionals to be able to address that. But also in terms of budgeting and funding for mental health, especially among adults, it's very limited. So, and when we go down to adolescents who are living with HIV, the challenge is the issues are even higher. They are advancing burden of mental health challenges. Remember, I told you the 3 things they have to go through, and those escalate also their mental health challenges. Yes, there are few economic and human resources dedicated to this situation. So think about the child who was born with HIV, they not only have to deal with that, but they also have to deal with the mental health challenges that come with that. So part of my original work, part of my work that is performing this work, I was really interested in the psychosocial mental health functioning of children impacted by HIV. And these are children who are either orphans, so they lost one of those parents, and children who are living with HIV. So some of my area publications are focused around those issues, and taken together, there's a high burden, I said, but also when you look into gender, girls are more at risk compared to boys. And collectively, they point the need for mental health interventions to be able to support these children, however vulnerable they are, so that they can live, somewhere to a normal life as other kids. So the first study that I'm going to present about was focused on really understanding the social support systems around for children affected by HIV, specifically those who are orphans. And I was interested in the support outside of the family unit, right? In most sub-Saharan African families, the burden of caring for children who have lost parents falls on the extended family, but there are no government safety nets. So I was interested in understanding why are some children doing better than others? They're all going through the same situations, but why are some doing better than others? What are some of those support systems that we are not targeting, we are not looking at, we are not exploring? So my first study was to understand some of the non-support networks available to children, and where they're participating in a family strengthening intervention that utilize economic strengthening will be associated in extending some of those networks. So I used a data set of 1,410 adolescents, which is a bridges to the future study. And these were children who were orphans who were in school between 10 and 16 years. And also they were enrolled in the last year of primary schooling. They were recruited from 48 schools. And the way I measured these networks was to use, the name generator technique, where you ask if they have somebody who will support them outside of their family members, and the type of relationship, timing of receiving support, frequency, and all that information. So I went in thinking that, okay, it takes a village to raise a child, right? Obviously, there are going to be people supporting these kids. It was, obvious. But what I found
that yes, I had about 82% of participants who said, yes, I have somebody. But when you look at the relationship, the majority of those, 66%, actually identify somebody related to the project, so related to the study. So the interviewer, the mentor, those, those temporary networks, they are the ones they identified. And 18% of those, almost 18% of those, did not identify anyone, which means if you take away the auntie or the grandmother who is caring for them, there's nobody to support them. So for me, that was very unexpected, and it really opened my eyes. And even participating in the intervention itself did not impact, so it did not help in creating new networks for these participants. So that led me to, because I kept asking why, for me to have been obvious. So I wanted to understand why are these kids not reporting anyone, and what is going on with these families that we are missing. So I designed a qualitative study with a sample of 38 just to try to understand how the intervention is, impacting these networks, but also some of those barriers to identifying other non-kin support. So the intervention did strengthen the existing relationships with family members. So because communication with caregivers, reducing the caregivers' financial burden. However, participants also identified barriers. So some of those, number one, was stigma. Stigma attached to being an orphan. Remember, this child may or may not be HIV positive, we don't know. But by the virtue that they had lost a parent to HIV, they were stigmatized in the community, which was very unfortunate. And also other things such as the lack of trust, of feeling uncomfortable, asking for support. But that became my aha moment, that if kids were not HIV positive are being stigmatized, so what is going on with those who are living with the infection? So I've taken together these findings point the need to integrate some of those social support services to combat issues around social isolation, stigma, and improve children's well-being. Because my takeaway from that was that these kids are really socially isolated, not because they have the disease, but because they're orphans. So being an orphan itself is stigmatizing. So we tend to talk about stigma, but also we talk about discrimination, and I wanted to to offer the difference between the two. So stigma is really like a mark that is put on somebody, intended to diminish them, to diminish their capacity, that you're not equal to us. And some of the stigmatizing conditions for youth who are living with HIV, maybe verbal insults, maybe stereotyping them, maybe prejudice, talking behind their backs, all those things. And then when we talk about discrimination, because of those, it's an act, right? You exclude those people from participating in things because of their condition. So because you have HIV, don't sit near me because you have that, you're not invited to be here. So those things. And if discrimination prevents you from enjoying your human rights, things you're supposed to, then it becomes a human rights violation, which is, cuts across public health challenges. So what do we know about stigma? So stigma is a barrier to all aspects on the HIV care continuum, right? It prevents people from testing and knowing their status, because if I know that I'll be discriminated against, I am not going to take that test. If I do, I'm not going back to get the results. I don't want to know what comes after. And the other part, it also prevents people from adhering to their medication, right? Because it prevents people from disclosing their status. If people don't know that you're HIV, you're less likely to take medication in front of them, because they'll ask, why are you taking your medicine? You don't have to tell them. So what people do, they don't take it. So they don't take it in the way they're supposed to. So, and actually that's a huge issue with children, who are in school. In school, everybody's in your face, so you don't want to until you get back home. And we don't want that, because we want to promote adherence and virus suppression, because virus suppression is equal to untransmissible, so the U is equal to U. But because of stigma, we are unable to get there. And the other part is also prevents people from accessing the broader sexual and reproductive health services, because these are also tied to, to HIV transmission, or you want to access contraception because maybe you're promiscuous, or you don't want to access condoms because, all those things are attached with the stigma. And also other infections that comes up with living with HIV, such as TB, where people are not afraid of going to get tested. And people who are living with HIV and who report high levels of stigma are 2.5 times more likely to delay enrollment and care. The other part is stigma associated with adverse physical and psychosocial outcomes. This is actually documented in my own research. And also family members are condemned by virtue of living with an HIV-infected person. So if your sister is HIV positive, it's your fault. How could you allow your sister to do that, right? So those family members also feel stigmatized because of that. So when we look at HIV and HIV stigma and discrimination by the numbers globally, across countries, so there's a survey across countries, 21% of people living with HIV report being denied health care in the past 12 months. Can you imagine? You can access healthcare because you're HIV positive. And by the way, so stigma and discrimination goes beyond even healthcare. It's in our workplaces, it's in our communities, it's in our schools, and it's embedded within the laws of countries, laws and policies. So 21% denied healthcare, 30% of the people living with HIV being forced to submit a medical or health procedure in a healthcare setting. Okay, just think about that. And women, 26% of women living with HIV reported receiving HIV treatment for condition taking contraceptives. That's a violation of the human rights. The meaning, women, because they're HIV positive, they can't have babies. So that is unacceptable. And also, more than 50% of people that's ages hold discriminatory attitudes toward people living with HIV. And by the way, this is where the majority of our interventions are. Interventions targeting the non-infected and how they're supposed to behave towards those who are living with HIV. But then look at the percentage of people who actually still hold those attitudes and beliefs. And also others, 47 countries still maintain travel restrictions for people living with HIV. That is unbelievable. So what are we going to do about this? So, the other part, HIV is at the core of the global HIV of the global AIDS strategy. So strategy 1 is focused on addressing those equitable access to HIV treatment outcomes. That strategy, the second one is breaking down some of those barriers to acquiring HIV outcomes, and stigma is at front and center of that strategy. So you have heard about the 95 targets, and people know their status, get on ART and then very suppressed. So we have the 10-10 targets for HIV stigma and discrimination. We are less than 10% of people living with HIV only, so we hope to get to less than 10% who report internalized stigma, key population report experiencing stigma, general population report discriminatory attitudes, and also in law enforcement. This is really targeting people who are living with HIV, but also those who are at risk of HIV. Okay, so with all that, and with all the strategies that are put in place, there's still some gaps. Children living with HIV are still underrepresented, and those intervention targeting stigma reduction strategies focus on reducing fear among those who are not infected. How do you treat somebody living with HIV? However, we've seen that still more than 50% still hold those stigmatizing attitudes. And also, there are several theory-informed interventions that we know they're effective, they've worked in reducing mental health-related stigma. Why don't we adapt those test them, and see if they work for HIV-related stigma. That's where it's coming. So the potential to utilize either, and these are group-based interventions, cognitive behavior therapy and family strengthening interventions that are delivered via multiple family groups. So a group of families experiencing the same situation coming together and receiving that intervention. So many of you have heard about group cognitive behavior therapy, or just CBT. It has been found to be effective in reducing mental health stigma and using those core components of psychoeducation, just teaching people how this works. What are the symptoms? How does it come about? How does it impact your thoughts and behaviors, those things? But also giving you some of the resources, all the skills you need to be able to address the negative thoughts and improve positive thinking. And the other intervention is the multiple family group, which is really focused on addressing specific factors that are tied to poverty, and in this case HIV. So the stress that comes with that. So imagine, okay, that they're poor, they have to take care of the family first, but also have this child who is HIV positive with high demands, right? So the stress around that will impact everything, the family functioning, including discipline, the family support, communication, those will be impacted. So this intervention targets the entire family, and the core components that we call the 4 R's and 2 S's. So it focuses on rules, responsibilities, relationships, and respect, and also trying to identify and address the stress within the family, but also improve social support. So this leads me to my second study, which uses, as we call it, SUBI, for stigma, SUBI is Uganda word meaning call. And the aim was really to pilot test whether the 2 interventions, group cognitive behavior therapy and a multiple family group, is feasible, acceptable, and what are those preliminary impacts on children's outcomes, specifically on stigma, but also on their mental health functioning. And the second aim was really to look at the participants' experiences with the intervention and also the facilitators and barriers to intervention participation. But I'll focus on the first one. And the theoretical framework, so the work is guided by the HIV stigma framework that identifies several mechanisms through which stigma impacts the health and well-being of individuals. So internalized, which involves taking all the negative beliefs and stereotypes and attitudes and applying them to the self. So you agree with whatever everybody is calling you. And the other 2, anticipated and enacted, they're really external to the individual. So an anticipated is what you expect how other people will treat you. And also enacted is what you actually experience. So if somebody discriminates against you, that will be an active stigma. But all these are impacting the different aspects of the prevention of taking your medication, social support, they impact all those aspects. So the hypothesis is that if we implement or test these 2 interventions, we'll be able to improve some of those factors you see in the middle, mechanisms of change. So we'll be able to improve peer and family support and communication, also keep the participants who will know skills around addressing stress that comes with stigma, and then we'll eventually be able to improve some of those outcomes. So this study was started in 2020. We recruited 89 child caregivers. Again, the sample is small because this is a pilot study. So we recruited a child and their caregiver from 9 health clinics. And this is how the intervention works, the study works. So we have the usual care, we have treatment 1 that receives the multiple family group, and treatment 2 that receives the group cognitive behavior therapy. So we had to go through intervention, adaptation, and training. Remember, I mentioned these are interventions that have been implemented to address mental health stigma, right? So they've been created to address issues around mental health, but also mental behavior difficulties. Now we want to adapt those three interventions, be able to implement them in healthcare setting to address HIV-related stigma. So we went through a process of engaging mental health care experts in the region to be able to adapt the content, make sure it's culture appropriate, but also age appropriate for this young age. So we adapted both, and they were able to draw some pictures that they wanted us to put in the manual in each session. And these sessions were delivered by trained counselors and also peer parents. So because in the beginning I mentioned that we do not have the trained resources, the trained individual human resources to be able to deliver mental health services. So for these interventions, we're actually working within the clinics and training those people who are called them counselors that work with children and train them to deliver these interventions, and as well as peer parents who are actually young people's parents and are trained to deliver. So these are children who are prescribed medication between 10 to 14 years. And so we collected data. We at baseline intervened for 3 months and then collected data at 3 and 6 months follow-up. So then there are many 147 diets actually turned up for recruitment, and they went through screening. 58 diets now made the inclusion criteria. So I want you to look at the number because we're not disclosed to. So these are children, they're taking medication, they do not know why. Right? So you know the reason why they're not disclosed to? Yes. They give us don't want their kids to be stigmatized. Okay? Because if they're young, it's not their fault. They were born with a disease, right? So what they do, they'll just tell them you have a headache, or you were born with a condition and you have to be on this medication without actually telling them that they're HIV positive. So they don't know. And unfortunately, those kids could not be included in our study because we're going to talk about HIV and everything else for kids who know. So they were excluded. But we ended up with 89 diets who were recruited. So we made our most like 19%. So these are some of the baseline sample characteristics. I'm not going to go through all of them. So in terms of feasibility for the intervention, and we looked at attendance for both interventions. And by the way, this was implemented in the middle of COVID. So 2020, 2021, that this was our attendance rate. So that's a success in my books. And this way is the participant satisfaction questionnaire with the intervention. So really, trying to understand whether this is something that is acceptable to the participants. And there's the numbers. 80%, 83% as the program helped them to do effectively with stigma. 86 they would return to the program. So in terms of some of the findings, these are baseline findings. So looking at stigma, shame, and also psychosocial well-being. So this finding was really interesting because I went in thinking, oh, it's stigma that is impacting, the children's psychosocial function and mental health well-being. That's how the intervention, the entire study wrote around that. However, and this is before the intervention, I find that it's actually shame, not stigma, that is associated with the outcomes. Now think about it. These are 10 to 14-year-olds, and they are ashamed of their condition. They are ashamed, and they are growing up with this infection. But that shame is so high that it's impacting all the other aspects of their health well-being. So my stigma was not. And if some of the potential explanations around that, it could be that. So first, shame has been identified as most associated with psychosocial functioning. But also the other parts, because we're working in a region with high prevalence of HIV, so maybe, stigma for around children is reducing. Maybe could partly explain. But also the other part is because we're working with children who are younger, maybe that some of the discriminatory and stigmatizing practices may not be, they may not make sense even if they see that, because they may not know why somebody is treating them differently or, saying something different to them. They may not register that, but those are potential. But however, shame was front and center at this. And then other findings this is another paper which is forthcoming, among caregivers for those we saw that stigma was associated with both their mental health and also parenting stress. And because we know they're dealing with so many things going on, but also on top of that, they have to take care of the child. And these children depend on their caregivers for their adherence outcomes. So in terms of the other preliminary impact on the selected outcomes, so things around shame, internalized stigma, anticipated stigma, over time, so 3 months, 6 months, we see, some of the improvements or reduction in shame, internalized stigma, anticipated stigma, depression. But when we look at the groups, we see that those who participated in the multiple family group had lower levels of shame, and those who participated in group CBT registered improved self-concept. So the both interventions are impacting at different outcomes. So which really we will need to further test these two interventions, because this was just a pilot study, but we want to read a bigger study where we are able to test the impact, the effectiveness and efficacy of these two interventions. And that's the plan. That's the next goal. So there are also a few ongoing studies in the beginning, the severe adherence and bridges studies. So these are they're called competitive renewal. So they're building a cohort of youth. So the first study was 5 years ended, and then we are adding on, we are following it up on the youth who had intervened with, to see what are the longitudinal outcomes, what are the longitudinal impact of participating in an economic intervention on treatment adherence, but also on HIV risks among youth who are now transitioning into young adulthood. So the first study is for youth who are living with HIV, and the second study is for youth who are due to HIV. And then the last study, which I'm very excited about, got funded about a month ago, is for sub-Saharan. So again, when we think about trying to improve the treatment outcomes, but also the mental health outcomes of youth living with HIV, right now we are thinking through technology and how we can leverage that, given that most sub-Saharan African countries are embracing technology. So how do we embrace that to be able to intervene with people and improve some of those outcomes? So the sub-Saharan health study is the objective is to develop a mobile health intervention for use among Ugandan youth living with HIV, but also with depression, because we know high levels of depression are also associated with lower level. Kids are less likely to adhere to their medication. So that's where we want to intervene. So this study will be implemented into phases, and the first two aim are really exploratory to refine the intervention protocol. So for us to be able to understand, if we were to develop this intervention, what are the things that youth would like to see? So in terms of the content, in terms of let's say its features. So what would you like us to focus on? The format, the language, the activities, those things. So we want the youth to let us know what they would like to see. And then following that, we'll be able to refine that protocol and explore on a small scale, test that out on a small scale of 30 youth to see whether it's acceptable and feasible. And then the second phase of the study will be to test the preliminary impact of that phone app reducing stigma and improving adherence. And again, so the content will be based on the CBT content, so the group cognitive behavior therapy, which we know there are not enough people to be able to implement this, but now we want to deliver it through the app. And the last part will be to examine some of the barriers and facilitate us for integrating the unhoused into healthcare setting. So bringing all these things together, because I've presented three separate things. So the challenge we have is addressing issues around HIV stigma and discrimination among young people, which we know is a public health challenge. Okay, and without addressing it, we won't be able to achieve the 95 outcomes for HIV treatment. But how do we do that? So we have several ways of doing that. We have the group-based interventions, which, demonstrating potential that they can address some of these, so the family strengthening, addressing CAT, and then the group cognitive behavior therapy also addressing some of these outcomes, okay? And then the third part is, even with that, is there another easier way that may be helpful to deliver those interventions? And that's where the mobile health app comes in. Okay, and that's my job. Those are some of the references. And thank you so much. I try to study independently because I know that I student that way into the next class.
Great, thank you so much, Dr. Proscovia, for your insights here and sharing with us your really important work. We're going to open it up for question and answers. First, I'd like to say that you have about 80 people attending on Zoom as well. On Zoom, I got word that the lapel mic is kind of fading in and out on Zoom. So maybe for the question and answers, we can use the podium mic. Okay. And we'll try to get to a question or two on Zoom, but first we're going to open it up to our in-person audience for anybody who has a question.
Angela, it's Ragini. It's also hard to hear you on the physical mic too.
Okay, in that case, if you have a question, if you'll be brave enough to come up and speak into the mic up here, that would be great. So can they hear us in this one? Ragini, can you hear us?
I can hear you all. It's cutting in and out.
Use that.
Thank you, Professor, and thank you for your wonderful research. And my question is what's the implication of cognitive behavior on mending the stoic children, the behavior of stoic children, because stoic children most of the time are not perceiving the communication or commands, whatever we give them. So do you categorize children behavior and have you seen the individual behavior result by implicating these methodology on them?
So thank you. Before you go, so I understand your question correctly. So you're asking whether we categorize children based on their behaviors?
Yeah, because most of the children have different level of stigma. The perception of their behavior changes are based on their exposure, bad impact of society on them. So their behavior and their perception to the commands are of different level. So do you use that behavioral classification like stoic or hysterical children or cooperative children?
Thank you so much. So for this particular study, because it was a pilot study, so we intervened with everyone. So all children that were recruited and we assessed for their stigma, so how they felt at the time, they were all intervened with. So we did not distinguish between high or low stigma. But I also know, so in other interventions, in more larger studies, so kids are screened for their for their behavioral difficulties, and everybody that's screened positive, they'll be taken, because you don't want to create another layer of stigma that, oh, why is that getting this service and I'm not getting these services? So to do away with that, we intervene with everyone.
Great, thank you. Other audience questions? We'll see if we can get this up on the mic.
Thank you. Dr. Nabunya, thank you very much for your wonderful presentation. I have a question about your finding about stigma versus shame. So I'm curious, can you talk a little more about how you measure shame and what was causing the shame, if not stigma? How you were able to disentangle shame from stigma, and if it's not the stigma that was causing the shame, what was causing it? If you were able to do that. Thank you so much.
Yeah. Then thank you, Dr. Leda, for an excellent question. So we measured shame and stigma differently. So because they're different, there's a measure that has actually been adopted in Uganda, and we used it in the severe adherence study, just focusing on shame. And then we use another measure, measuring internalized and anticipated stigma among this population, among young people, but also among the adults. So for the first finding where we found shame and non-stigma, we actually ran two different models, one including just the shame and one just including the stigma. And it happened that shame was front and center. And again, it's that shame associated with knowing that you're HIV positive. It is stigmatized because, you know, people think you got HIV because you're promiscuous, you are not careful with your life. Maybe it's the fault of your parents. So around that, as opposed to the stigma where people actually are in your face, you know, maybe you know, calling you names or in your face or discriminating against you, you're not supposed to be here. So for me, what I think is, you know, the idea that I'm living with this condition, there is no cure, and it's associated with, you know, like sexual risk taking, with, you know, is the reason why we see that it's shame and not stigma. I hope I answered your question. Yes. That's three, I think, 2 or 3.
Okay, one we have a chapter open and then we'll bring it back to our audience, and I'm getting that it is better when we stand closer to the podium mic.
Okay.
The question is, what are some drawbacks the research might have faced during the recruitment process? Being that HIV is such a stigmatized topic, especially in sub-Saharan Africa, how did they manage to get so many participants? How did you manage to get so many?
That's an excellent question. So the region where we're working with has the highest prevalence of HIV in the country. So it's about 11% compared to about around 5% of the national average. And this is an area where the first incident of HIV was first detected in the country. So as you can imagine, it has been 30 years, but the impact of HIV within these communities is visible. So the prevalence is still high, which means there's still children being born with HIV, and there are people dying of HIV in this community. So there are so many HIV clinics for youth. And when you go to these clinics during adolescent days where they have that, just a day for children to go for their treatment, it is heartbreaking because the numbers are extremely high. Okay, so that's one. But so on the part of the drawbacks, maybe what I would say, we might have got even more numbers, but because the study was implemented during COVID, we couldn't go to more districts because the country had restrictions around travel. So some districts were cut off, so which means we could not go to those districts because of travel restrictions. But we could have gotten even more numbers for that study. So, but overall, this is a region with high prevalence for HIV.
Amanda, question. Would you mind coming up and asking close to the mic so folks on Zoom can hear?
Thank you. I'm still thinking about how you use assess high shame and not stigma. But I'm thinking through again, for you to perceive that you are stigmatized, those that are stigmatized against you must know your condition. So how were you able to tell that the child that felt that wasn't stigmatized against, those that were, supposed to be against their child knew that he or she had that condition? Because shame is what you perceive. The individual with the disease perceive that means ashamed of self or himself. But with stigmatized, someone needs to know that you have the disease, then you can feel the stigma. So how then would you differentiate that really it was the person that the people knew the condition and doesn't mean, and even, I mean, knowing that, so the child wasn't stigmatized against. Do you want a question?
May I say something?
Please, go ahead. Yeah, I think.
Yeah, so. Yeah, I understand. So I think that's an excellent question, but I think that when Dr. Nabunya was introducing stigma, he distinguished there is internalized stigma and there is externalized stigma. So internalized stigma may be you feeling that they know when even you don't know whether they know. You understand? So it's within you. It's like you thinking that she loves me when actually she doesn't love you. And really, seriously, you know, it's that kind of, it's within you. So it's internalized, it's within you. I'm HIV positive. So these kids had to know that they are HIV positive. Am I right? They had to. That's why I think she eliminated those who didn't know.
Yeah.
So when you know, then you may start feeling ashamed, but you may also think that I think the way she's looking at me like that, or he's looking at me like that, or they're looking at me like that is because I'm HIV positive. Although they may be looking at, I mean, you know, for those ones who have dated, you have looked at someone and they smiled at you and you think, I think they love me. Maybe they are smiling because you dressed well or because you dressed poorly. So I don't think that really the issue is that the other people must know for you to be able to tell that I'm stigmatized. So that's what I wanted to clarify. We should not confuse internalized stigma with externalized stigma. Externalized is from the people outside so that they know. Internalized is within you. They may know, but they may not know that you are HIV positive. So it may be just your consciousness.
Yeah. Thank you, Dr. Fred. Did that answer part of your question? But so in addition, also when we look at stigmas, because there are different mechanisms, so we also measure internalized, but also anticipated stigma from others, right? So we are able to distinguish between the two, or the three.
Good question. Audience here?
Now,
Angela, we have one more in the chat. Oh, sorry.
We'll get to that one next.
Yep, sounds good.
Excellent presentation. So for the benefit of the students in the class, what I wanted to ask is, yes, there was, you know, you were able to recruit a very high number of participants in the middle of COVID. But we also know that ICHAD interventions or research we do, there's very high retention rate and all. Can you speak to what are the basic mechanics of how do you do this? How do you form partnerships? How do you conduct a research and all of this so that at least the students can get some, you know, information on how they do this? Thank you.
Yeah, thank you so much for that excellent presentation. And actually, this is one of the most important pieces that we tend to neglect when we present just the research findings. So I will note that this study was conducted in our region where we have built collaborations for over almost 20 years. So we've worked in the same region for all that long. Remember, it's always important to, to invest in the community where you're going to do the work. Don't just go in, collect data and leave. That's not the way to build collaborations and capacity. So one part is we have stakeholders in the region who we have worked with. So even in these clinics, if we go, we are thinking about this study, and we're thinking about doing it in the clinics or the schools. So we have them on board from the word go, from when we write the grant, and then the implementation, they're part of that implementation process. That's why I also noted that in adapting our interventions, we engage with the mental health experts in the community. The people who are delivering the intervention, community health care workers, they're counselors at the clinics, they're parents, peer parents that are trained to be able to do the work. So even when the project ends, these individuals are training, so we build the capacity. They can also implement this in their own clinics without, it being part of the study. So having those strong collaborations, those relationships, which we have built for a very long period of time, is very essential for the work, because recruitment, we get the numbers, but also when we go back to follow up on participants, we are able to work through the stakeholders, the clinics, to be able to follow up. But also the other part, when we recruit, especially for longitudinal studies where, participants are followed for a long period of time, you have to get their information, their contact information. So, you ask them where they live, but you also get information for 3 to 5 other people who will know where these participants are at all time, even if they move. Okay. So when you go back the following year to follow up and you don't find them at home, you have the contact of, a few different people that you can contact to get to those individuals. And all our studies, we've been very fortunate to have retention rates of 97, 96% for kids followed up over a 5-year period. So, but engaging with the community, building those collaboration with stakeholders, and also building capacity within the clinic. So within the community. So the issue around building capacity. So you are engaging them in the research process. So you're training graduate students in the community. So, those individuals to be part of the research process. They're trained as project coordinators and data collectors and mentors. So they're young, but they grow into the research. The community know them. So it's not like you're bringing foreigners in the community to be able to interview other people. I would actually use people within the community to be able to do the work. So those are some of the things that have helped me and my team to be able to advance this work.
Yeah. And let's get the question from the chat. Ragini, if you could help us out, do you mind reading the chat question?
Not a problem at all. Hi, everyone. So we have a chat question that says, were there any distinctions between participants who had lost one parent to HIV as opposed to 2?
Thank you, Ragini, for that question. Yes. So there are some differences that I did not provide in this presentation. Actually, those will be forthcoming, but yes, we saw some differences. Yes. My presentation.
Are there any questions? Let's see if we can pull them back. Would you mind please coming up and asking your question into this mic?
Okay. Thank you for your presentation. So I know that they were excluded from the study because these children didn't know they had HIV, but just in your other research or experience, have you seen any ethical implications or consequences of children being treated although they don't know that they have HIV?
So thank you so much. So yeah, there are implications for that. So when people are not disclosed to, means they may be less likely to adhere to to their treatment protocols. But for children, it's a challenge, because if they're growing up taking this medication and the parent did not tell them why, once they find out, it's usually an issue. It's usually a problem. It creates problems because now the child is blaming them, the parent. Why did you do this to me? If you knew you were HIV positive, why did you give birth to me? And because they are adults, and so they will discontinue taking their medication. We've had cases where kids are refused because they're angry and disappointed in their parents for bringing this to them. And once they get off of track, so if they were adhering to the medication, they stop, it means they'll be unsuppressed, and then there are all these there are other infections related to that not being adherent. And also it has implications for HIV transmission, because if they're not suppressed and they're engaging in sexual activity, they'll be able to transmit the infection to another person. But yeah, so the issue around not being disclosed to, it is actually impacting their treatment outcomes, but also their emotional and health well-being.
Yeah. May I add something here? That really the whole disclosure is a big area by itself. that you cannot just disclose to a child, because ethically, you cannot just get a child and you disclose to them without preparing them mentally. So there's a whole list of protocol that you have to go through. And if you're a researcher and you go in and a kid, you say, oh, you are taking your medication, they have never told you that you're HIV positive, you're HIV positive. You may create a suicide or whatever and that kind of stuff. So that's a different section altogether in terms of research, that you need to have counselors. They have to prepare this child, and then they may even have to come back to make sure that, are you ready to know, and that kind of stuff. And that's not what I think Dr. Pros's study was about. Her study was to deal with young people who already know. Now, you can write to NIH and just do a disclosure study, and that's also a different kind of arrangement that one will have to go through. Otherwise, people would think that, oh, that's unethical, the kid doesn't know, and then you are excluding them from a study. It's better for you not to tell them there and then than for you to disclose to them without preparing them mentally.
Okay. I think Rachana, and I think we have time for one last question, and then we'll wrap it up after this.
Thank you so much for sharing. And we have two more questions, but they are related. First is that, do you stratify, like in HIV research, do you stratify the participant who enrolled in ART based on their first line, second line, or third line therapy? Because in my experience, I think that each drug has its own side effects, like adaptation is more than the bigger stuff. Second question is that, you think that medicine side effects could have association with the psychological and mental health of the study participants?
Thank you for that excellent presentation, that question. So to answer your first question, no, do not stratify by their line of HIV medication. Though we collect the data to understand who is on first line or the second line, but we not stratify. So,
So the second part, do I think that, you know, the medication is impacting their mental health outcomes? Absolutely. And actually studies have documented the bi-directional relationship between adherence to medication and also mental health. So if you're adhering to your medication, you're more likely to report improved mental health outcomes, but also if you have poor mental outcomes, you're less likely to adhere to your medication. So it's a bi-directional relationship.
Thank you so much, Dr. Prosky, Dr. Fred, ICHAD faculty and staff that are here. Thanks to all our students who have attended. Let's please give Dr. Prosky a nice warm. I appreciate your time and your energy here and educating us on this really important topic. So thank you so much for being here. Thank you. All right, thank you, everybody.